a lethal zebra within a Trojan horse. Ectopic ACTH secreting tumors are responsible for around 10% of all cases of Cushing syndrome. Few cases of colon adenocarcinoma with paraneoplastic ACTH secretion have been reported. They are associated with an adverse prognosis. Tissue and radiological testing are frequently misleading. We report a case of totally negative metastatic adenocarcinoma of the ascending colon that presented with ectopic ACTH syndrome after FOLFIRINOX and dexamethasone therapy was started. It was a 57-year-old previously healthy male who presented with elevated blood pressure and shortness of breath. CTA of the chest showed multiple liver lesions. Subsequent CT abdomen and pelvis confirmed metastatic liver lesions with an apple core colonic mass consistent with primary malignancy, as we can see in figure 1. Liver biopsy showed well-differentiated neuroendocrine tumor. Colonic mass wasn't biopsy at that time. Total scan was negative for somatostatin uptake, showed in figure 2. He was started on carboplatin and etoposide in combination with dexamethasone. He got 3 doses of 4 milligrams each of dexamethasone. 2 months later, he presented with large bowel obstruction. Histopathology of the colonic mass revealed colonic adenocarcinoma with focal neuroendocrine differentiation. ACTH stain was negative. Chemo was switched to FOLFIRINOX and dexamethasone. He received a one-time dose of 12 milligrams. 2 weeks after starting this new regimen, he was sent to the hospital due to hypokalemia, metabolic alkalosis, and leukopenia. Vitals were normal except for elevated blood pressure. Physical examination was remarkable for redness of his truncal skin. He did reveal changes in handwriting, 0 out of 3 word recall, and reduced short-term memory. Endocrinology was consulted due to elevated morning cortisol, as we can see in the table 1. An 8 mg overnight dexamethasone suppression test revealed a paradoxical increase in cortisol, which was confirmed with dilution testing. MRI brain showed no evidence of any intracranial abnormalities. Prior to noticed hypercortisolemia, chemotherapy-induced Bartter syndrome was considered, which could explain hypokalemia and metabolic alkalosis, but will not explain hypertension and cognitive decline that was seen in that patient. Non-suppressible hypercortisolemia emerged as the proximate cause of his presentation. Refractory hypokalemia due to ectopic ACTH-dependent Cushing syndrome was diagnosed, warranting treatment with ketoconazole. Unfortunately, he developed septic shock during his hospital stay, which led to his demise. Colon adenocarcinoma with neuroendocrine differentiation and paraneoplastic ACTH production is a rare but lethal condition that has been reported a few times previously. Sigmoid colon is the most common site of involvement. Symptoms include back abdominal discomfort, diarrhea, constipation, gastrointestinal bleeding, fatigue, malaise, and weight loss. 60% of the patients have negative stains for ACTH and other neuroendocrine markings, suggesting that many of these tumors have a poorly differentiated neuroendocrine component or de-differentiated by the time of presentation. Dexamethasone suppression tests performed in 57 of the review patients uniformly led to a paradoxical rise in serum cortisol levels, suggesting the presence of positive feedback effects of exogenous corticosteroids on tumors' ACTH release or production. This hypothesis is further strengthened by our patient developing clinically significant hypercortisolemia after receiving 4 doses of dexamethasone, presumably triggering a positive feedback loop.